So in late 2020, the Canadian Cardiovascular Society published an update to its comprehensive guidelines for the management of atrial fibrillation. This is a very important document. It covered all aspects of atrial fibrillation management, including classification and definitions, epidemiology, pathophysiology, the soup to nuts on how to evaluate somebody with atrial fibrillation. It talked about screening, an integrated approach to management, stroke prevention, management of symptoms, arrhythmias, and in particular, this was a special document in that it talked about sex differences for atrial fibrillation, which is something that is new in the guidelines. And finally, special populations like children, for example. This document is a cornerstone for Canadian clinicians to manage atrial fibrillation according to the best evidence. The CCS uses a rigorous process for gathering the best evidence in the medical literature, synthesizing it, and coming up with specific recommendations about how clinicians should put this evidence into practice. And all of this is centered on the best possible outcome for individual patients across the country.
Understanding the quality of atrial fibrillation care delivery is critically important for identifying care gaps, targeting improvement efforts, and to guide resource allocation. In Canada, this effort has been led by the Canadian Cardiovascular Society. As co-chair of the CCS AFib Quality Indicators Working Group, I would like to highlight two publications using the Vigor Pop Health Research Lab to report national data on key AFib quality indicators. The first publication examined trends in incident non-valvular atrial fibrillation hospitalizations, stroke risk profiles, and associated in-hospital mortality over the time period from 2006 to 2015. A total of 578,000 participants were hospitalized with incident non-valvular AFib in any diagnostic field. Median age was 77 years, 82% were 65 years or older, 54% were men, and 69% had a CHA2DS2-VASc score of 3 or greater. The overall age and sex standardized rate of non-valvular AFib hospitalizations was 315 per 100,000 population, and it declined by 2% per year, which was significant. The majority of patients were at high risk for stroke without significant trends in risk level. The average adjusted in-hospital mortality was 8.8 per 100 patients, with the 2% annual decline in the rate over the study period. The conclusions emphasize the need for further investigations to evaluate whether changes in AFib risk factors, ED practice patterns, admission standards, and extent of outpatient AF care may contribute to the declining hospitalization rates. Determining risk of stroke for patients with AF, a priority quality indicator, demonstrates that the majority of patients are at high risk. Hospitalization provides an important opportunity to initiate oral anticoagulant therapy or document reasons for contraindication. The second publication examined trends in one-year incidence of stroke or systemic embolism, major bleeding, and heart failure for patients discharged after a first hospitalization with incident non-valvular atrial fibrillation. The study period and the cohort characteristics were similar to the prior publication. Within 1 year of discharge, 3.5% were hospitalized for stroke or systemic embolism, 1.6% for major bleeding, and 8.6% for new heart failure. Over the study period, risk-adjusted yearly rates of incident stroke or systemic embolism and heart failure declined by about 1% absolute values, while major bleeding remained unchanged. The conclusions highlighted the need to study process-based quality indicators with increased focus on heart failure prevention. These publications illustrate incremental progress in our ability to assess the quality of AF care in Canada.